Assalamu alaikum and welcome to this recorded lecture on gynecological emergencies. This is a lecture where we discuss several cases, and I want you to have a pen and paper by your side to kind of look at what your thoughts, to write down your thoughts and your answers to these kind of questions at the different steps are. Okay, so we start immediately with the first case. This 32-year-old woman had an IUS, or an intrauterine system, inserted 3 weeks earlier. 10 days ago, she presented to the emergency department with acute abdominal pain. The threads were not visible at the time, and on the ultrasound scan, it looked as if the IUS had kind of migrated into the right cornu of the uterus. An appointment was made for hysteroscopic removal, but she presented with more abdominal pain in the interim. So what do you have to do next? And you're right, you have to do an examination next. The abdomen is soft, there's generalized tenderness, and the threads are not visible. What's your next step? The ultrasound scan, that's correct. The uterus is anteverted, is normal in size, the endometrium is 11 millimeters, and the IUS is not visible. Even on the ultrasound scan, there's no IUS. What are your thoughts, and what do you need to do next? An abdominal X-ray. And what can you see here on this abdominal X-ray? Yes, there's the IUS in the pelvis. So what has happened? The IUS was, the uterus was perforated, which usually happens at insertion, at the time of insertion. So this fits with the time about 3 weeks ago. The IUS, the IUS was inserted at the same time the fundus was, or the uterus was perforated, and the IUS migrated into the abdominal cavity. So what have you got to do here? Oh, first of all, let us see which other investigation is important. The pregnancy test, yes. So she did not have any good contraception all this time, because this was not in the right place. So she needs to have a pregnancy test to kind of make sure there's no pregnancy. This was negative, as I said. And then you have to plan for laparoscopic removal of the IUS, which is can be very easy if the IUS is kind of lying at a place which is easily accessible. But if it's kind of sunken down between the small bowel loops, it can also be quite tricky and annoying. But it is only a laparoscopy usually. After that, the lady needs to be discharged with antibiotics so the uterus can heal, but otherwise it heals spontaneously. Even if, in this case, if you have to think about, and this is maybe the bigger problem for this patient, is what contraception do I use after this? So maybe blind insertion of IUS, doctors and kind of nurses would feel anxious about, and this is understandable. Even the patient will feel anxious about this and feel, oh, I don't want to have another such perforation. It is, however, possible, if the uterus has not got an obvious defect or anything like that, it is possible to insert another IUS at the time of the surgery under laparoscopic vision. Okay, so that laparoscopically you can kind of see that the IUS is inserted in the same place. This is only advisable if this patient does not wish to consider any other contraception. Okay, so let us talk about the next case. This is a 27-year-old woman who complains of left iliac fossa pain. It started at night while she was asleep and woke her up. Initially, it was constant and severe, and she was unable to get out of bed. She felt nauseated all day yesterday and did not eat anything. But today the pain is still there, but much better. She was able to have a breakfast. What further questions do you want to ask this patient? Did you have this pain before? So is it for the first time, or did you have it before? She did have this pain twice before, but less severe. Which contraception do you use? She uses the progesterone-only pill for contraception. She's nulliparous, and she has been with the same partner for the last 3 years and has never had a sexual transmitted illness, infection. No gynae history and no past medical history either. So what do you do next? That's right, you want to do an examination. The results of the examination are that the temperature is 37 Celsius, her blood pressure 122/78, and pulse is 76 per minute. The abdomen is slightly distended with some tenderness suprapubically and in the left iliac fossa, with no guarding but some rebound tenderness, but no masses. Speculum examination is normal, and bimanual examination shows some tenderness in the left adnex, but no masses are palpable and there's no cervical excitation. So what do you want to do next for this patient? That's right, you need to have a pregnancy test. This is very important, and this is negative in this patient. What are her bloods? You need to have her bloods, and the bloods are hemoglobin 12.8, white cell count 7.1, platelets 320, and CRP 2.5. Urinalysis is also negative, so completely normal. And you need the transvaginal ultrasound scan. This shows a uterus which is anteverted and of normal size, a thin endometrium, and both ovaries are normal. However, there's a moderate amount of anechoic fluid in the pouch of Douglas. A moderate amount of anechoic fluid in the pouch of Douglas. This makes you think of several possible reasons. There could have been, so anechoic fluid can be there after menstruation sometimes. It can be there after cyst hemorrhage, cyst rupture, sometimes torsion. The pain she has might also have been due to irritable bowel syndrome or renal colic, but this is less likely in the kind of how she presents. An ovarian pathology is more likely here. So because she's getting better, you remember her history, she appears to be getting better, and this was for the first time. Her ultrasound is normal. You can think that this is possibly a ovarian cyst rupture, because this is typically like that. A cyst, if a cyst ruptures, then there's some pain, the pain peaks and then it gets better with time, and you also find some fluid from the cyst within the pouch of Douglas. So management for that would be supportive. You have to, of course, explain to the patient what happened, and you might want to suggest to her to change from the progesterone-only pill to a different form of contraception if she can, as the progesterone-only pill has been associated more than other forms of contraception with cysts. So she could have another form of progesterone-only contraception. For example, she could have the IUS. She could also have the implant, both of which are not associated with the same, so ovarian cysts. The next case is a 17-year-old girl who presents with a painful lump at her vulva. She noticed it 2 days ago, and now it has increased in size and it's really painful. She cannot walk because of it. She is not married and did not have this before. What other important? What is important? What else do you need to do? So you need to ask about examination. You have to do the examination. Vital signs are very important, always in any emergency, actually. Abdominal examination is normal. So you can see she has got a temperature of 37.7. And on examination, you find at the genitals a left-sided posterior labral swelling, extending to the introitus and measuring 6 by 4 by 4 centimeters, roughly. It appears red, fluctuant, tense, and is tender to touch. Bilateral tender inguinal lymph nodes are also palpable. What was important to ask? If she has been sexually active before, if she's married, but she's not. She has not been sexually active before. So this is a Bartholin's abscess. Bartholin's abscesses are mixed flora. Abscesses mostly, 20% have gonorrhea. Also chlamydia can happen. In a patient who has not been sexually active, it's more likely just to be a mixed flora bacterial abscess. Treatment is by marsupialization. And it is very, very important to explain to this patient that recurrences can happen. If she feels a recurrence, she should be treated with antibiotics early on, because sometimes antibiotics can often antibiotics can kind of calm it down and not make it necessary to actually have marsupialization. So why are we talking about marsupialization instead of just incision and drainage? Because if you guys would have told me incision and drainage, I would have said, no, that's not quite right. We need a marsupialization here. This is to prevent recurrences, actually. So these are some pictures. So on the left, upper left picture, you see a Bartholin cyst on the right side. Then I have pictures from a marsupialization on the left side. So I'm sorry about this discrepancy. On the right-hand side, you see at first you do an incision of the skin, and you have to really make a large incision on the kind of top of the cyst, and it has to be a long incision, not a very small one just to drain out. It has to be a large incision of several centimeters. Then you do the incision into the cyst or the abscess, and there you can then drain and drain all of the abscess, make it empty. Once it's empty, you want to do the marsupialization, and you can see it on the picture numbered 7 in the left lower corner. You can see how the cyst, the kind of cyst capsule, is kind of sutured or kind of put with kind of either intermittent or continuous sutures with the with the skin, so that actually the cyst remains open. And this prevents a reforming of the reforming of this problem very soon. And in the 8, you see the end of the marsupialization. This is how it looks at the end of it. And this kind of procedure prevents a recurrence, or is supposed to prevent a recurrence. It cannot completely prevent a recurrence, but it reduces the risk of recurrence. Okay, next let us look at case 4. This is a 29-year-old woman who presents into the emergency department because she feels unwell and has not been able to pass urine for 8 hours. She feels pain in her groins, but feels generally unwell as well. She also has dysuria, which started yesterday, but has been getting worse since then. She has never experienced these symptoms before. It's the first time, and she has a regular cycle, uses the combined oral contraceptive pill reliably, has got no gynecological or medical history. She is married and has only had the one sexual partner. On examination, the patient is in a lot of discomfort. She doesn't. Her temperature is 37.4, blood pressure is 118/64, and heart rate is 112. The bladder is palpable midway to the umbilicus, and she has tender bilateral lymphadenopathy in the groins. So inguinal lymphadenopathy. The vulva is reddened with clusters of vesicles and ulcerated lesions bilaterally. The speculum examination is very tender, and you actually have to abandon it and not do it. These are the skin lesions that you see on the vulva. What is the differential diagnosis? This patient has genital herpes. This is a clinical diagnosis. I told you before in the year 5. It's a clinical diagnosis. You can see it, and it is very painful. What next? You should take a swab from the bottom of these vesicles, or either from scraping an ulcer, because you see vesicles and ulcers usually at the same time. So either at the bottom of the ulcer or from the vesicles. In the vesicles, there's a lot of viruses there, and also at the bottom of the ulcer, you can find viruses. And it is to really check and confirm the diagnosis, but also to know if you have genital herpes virus 1, type 1 or type 2 in this patient. Furthermore, you need to put in an indwelling catheter because this patient cannot pass urine and has got urinary retention. It might be possible for her, the urinary retention is an involuntary retention of urine due to the dysuria she has when passing urine. The dysuria happens by the urine passing over the lesions on her, so the ulcers usually on her vulva. And this can, of course, be kind of settled down by an indwelling catheter. Alternatively, you can ask her to sit in warm water, and by doing that, it might help her pass urine because the urine will kind of be diluted in the water and not be as tender. You can give her also anesthetic gel for local pain relief, and also treat her with acyclovir or valacyclovir. Valacyclovir is preferable because this is a treatment 2 times a day, while acyclovir needs to be taken 5 times a day, and then adherence to that treatment is much more difficult for patients. So what counseling is important for this patient? The counseling needs to include that she understands that she can pass this disease on to her partner by intimate contact, just skin-to-skin contact, really. The other thing she needs to understand is that she might get recurrences. This is not necessary, so there are some women who have primary herpes and never get a recurrence, but most women do get recurrences once in a while. Not that regular, but once in a while is common. So our next case is a 27-year-old woman who attends the emergency department with irregular vaginal bleeding and abdominal discomfort. She noticed bleeding 2 days earlier, needing to wear a sanitary towel. The abdominal pain is crampy and suprapubically, as well as slightly to the right side. She is systematically well, no bowel or urinary symptoms. Her last menstrual period was roughly 45 days ago. Her cycle is irregular, where she bleeds 4 days every 28 to 42 days, so she didn't pay attention when it was kind of delayed by 45 days. Contraception, she uses condoms. She has no other gynae, sexual or medical history, and she's nulliparous, but she's married. On examination, her blood pressure is 128/72 and her heart rate 80 per minute. Her abdomen is soft and not distended. Tenderness on deep palpation suprapubically and in the right iliac fossa. There's no rebound tenderness or guarding. Speculum examination is normal, and bimanual examination shows a slight cervical motion tenderness and right adnexal tenderness. What do you have to do next for this patient? A pregnancy test, absolutely. This is positive. Blood pressure, bloods show that she has a hemoglobin of 11.1. white cell count of 9.4 and platelets of 288, and an HCG of 1890. You have also got to check her blood group, because this patient is nulliparous and is likely not to know her blood group. But she very importantly needs an ultrasound scan. This is her ultrasound scan picture. On the left, you see the uterus. From a transvaginal scan, you see kind of a sagittal view of the uterus. This shows the uterus in full, and it very nicely shows that the uterus is empty. On the right, you see a picture of the right adnex, and there you can see a small sac in the right adnex, which is most likely to be what? To represent what? An ectopic pregnancy. So management for ectopic pregnancy should be guided by the local protocol. And in this patient, she has got medical, surgical options. The conservative option should not be offered to her because her HCG is above 1,000. If it's above 1,000, they should not. They should have either medical or surgical option. The medical option is should usually be offered to women whose beta HCG is less than 5,000, or some stipulate less than 3,000, and where there's no cardiac activity and the sac is less than 3 to 3.5 centimeter in size. So this sac was very small and there was no cardiac activity, so she could have either medical or surgical treatment. And medical treatment, of course, involves giving methotrexate, and it needs a longer time follow-up, but it is associated with a better result in terms of fertility and for the next pregnancy. Surgical treatment should be done by laparoscopic removal of this ectopic pregnancy. Unfortunately, often the parts or all of the ovary needs to be removed, especially if it's an ovarian ectopic pregnancy and not a tubal ectopic pregnancy. So in this case, medical treatment would be preferable, but this has to be discussed with the patient and it has to be viewed in the context not only of her wishes, also of what she can do. So will she be compliant to medical treatment, medical follow-up? Will she be able to come to the hospital if she needs to at short notice, and so on. So remember, in emergencies in women of reproductive age, you have to always do a pregnancy test. Bleeding can be life-threatening. You have to follow the ABC, so check the patient's kind of stability, and I know that usually you're very good at that. And you always have to do the vital signs as well, and then you have to kind of treat the emergencies according to their kind of presentation. Even in women of reproductive age, you should not forget other non-gynecological differential diagnosis for any kind of presenting emergency. Thank you very much.